So the thing to mention from my sort of speaker introduction is that I work in Wellington, and I've worked out late in life that I'm not very good at research, as you're about to see, and I've nearly published lots of papers, but I've worked out it's probably easier if I get other people to publish them and I just help with the data part. One of the things that we, I guess, haven't spent a lot of time thinking about within NZICS is the cost of stuff, and yet that preoccupies most of our managers' time. So I want to present a little bit of information about cost, and the sort of starting question was, could cost be a quality measure, as opposed to just knowing what something costs with that? The other thing I was going to say, for those of you who are Trivial Pursuits, Simply Red did not write Money Too Tight to Mention. It was written by the Valentine brothers 4 years beforehand, and they just copied it but made it more famous. So, what the joys of Google when I was looking for an image. So, we don't actually know a lot of stuff about costs. So, what are the costs? Are they different between units? Is that cost difference meaningful? Could we use that as a marker of quality? But even, is cheaper better, or would cheaper be worse? To take David's example of that sort of cross graph, do you want to be, if you're a more expensive unit, would your SMR go down or go up? None of this we really know. So I thought what I wanted would start with by looking at, can we validly use cost as a measure of quality? And this is why I'm not a good researcher, because this is now getting 3 or 4 years old, but I've been trying to work at it. But following from the CCR survey from 13-14, we asked some specific cost questions. 180 units replied. A bit less than half of them provided us with some cost data, but we're only 36 we could usefully use because they included the medical costs in their budget, which I'll explain a wee bit more later. So what we ended up with was some information about the total cost in your budget, the total number of patient days, and the number of beds, and a bit of staff stuff as a sort of baseline information to work off there. And the cost per patient day seems to be the appropriate measure to compare between units with that. And we calculate that by taking the total cost in your budget and dividing that by the patient days. And for Australia, the median's $4,200 per patient per day. So if you've got 10 patients in your unit, that's $42,000 worth of cost per day. If you've got 20 patients, it's double that. But it does depend on what's in the total cost, and we found about 30 or 40 units where the medical costs weren't in their unit budget. They were in somebody else's budget, like the anaesthetic department or somewhere else. So we had to exclude those units because they wouldn't fully represent the cost of the patient care. And the cost per patient day is good for comparing units, but it doesn't tell you much about the total cost, because that does depend on how long someone stays, as Dave's pointed out earlier. So the first thing I wanted to look at was cost versus the size of your unit. Now just ignore the colours on it to some extent, but you can see on the y-axis, on the x-axis, this is the size of the unit, and that's the cost per patient day. As your units get bigger, the cost sort of comes down, and there is a statistical association between those things. And you could think of a number of reasons why that might be. Just exploring this a bit, I looked at occupancy. And again, there is an association that says as your occupancy goes up, the cost per patient day goes down, which makes a bit of sense because certainly for doctors, there's a lot of doctors standing around and they don't go away just because the unit gets quiet. So the more patients you have, the more efficient you look. And it might surprise you, it might not, to realise, if I go back one, that in fact the bigger units end up having a higher occupancy. And I think that's a mathematical thing to do with how many spare beds you have to keep for acute admissions. And if you're a bigger unit, you have that number becomes a smaller proportion of your total beds. So it's probably got nothing to do with the practice, but just the bigger your unit, the higher your occupancy is, and therefore the cheaper the cost might be. So we looked at what were the components of the cost, and this is the first thing we found at the top here was the medical costs made up a quarter of the total cost of running the ICU. And this is why we had to exclude all those units that didn't have the medical costs in their budget, because it would underrepresent the total cost by at least 30%. Nursing makes up 50% of the cost, and those two plus some other stuff make up about 80% of the cost of what we do. So the reason we're expensive is because of all the staff, not all the drugs and clever things like that. Consumables and drugs make up 14% or 18%. If anybody has complicated haematology patients in their unit occasionally, you know that they have really expensive drugs and we don't. And labs and radiology and fluids make up a small amount of the total cost for that. So if staffing makes up the total cost, most of the cost of what we do, does the patient acuity have anything to do with it? Now, acuity is a bit hard to measure, certainly within the CCR survey. We can do that with the APD, but we do know how many patients you ventilate. So in theory, if you ventilate more patients, you might find that it costs more. And certainly if we do this in terms of the nursing costs per patient day and the percentage of patients you ventilate, there's a pretty straight line going up there, which just makes sense. So the more patients you ventilate, the higher that 1-to-1 ratio becomes and the more expensive it becomes per patient day. No one I think is going to be surprised at that. The median for Australia is about 40% of our patients is ventilated. So half the units are up there and the other half are down there. Now I'll come to why that's important in a moment when we come to do comparisons with that. This is where it gets interesting. So I thought, well, I've just looked at all these patients by size and by type of unit. What about comparing the different states? Now, the bottom line here is just a sequential number. It's meaningless. I just put them in order by state. So this is New South Wales over here with their cost per patient day. That's Queensland up there. Then you've got ACT here and Victoria down here. And it's pretty obvious that Queensland is standing out as being a lot more expensive. And that's what I didn't quite expect. I was expecting variations in terms of all sorts of things, but not by state. So we tried to think through what might be the reason for that. And of course, the obvious thing is if staffing makes up 80% of the cost, then staffing is likely to make up the reason why Queensland is more expensive. So what determines the staff costs that we have? Well, there's two bits to it. One is, what does it cost to employ a person? So what are your salary costs per FTE? And then, as Ed just pointed out, how many FTE do you need per patient episode that goes there? Now, I should point out that this is working, the staff cost, the FTE cost, is not their salary. So certainly for nurses it's probably close, but for doctors there are a lot of additional costs that aren't salary costs. Professional registration, indemnity and stuff, education and bits and pieces like that. So I went back and we looked through, we can do this sort of backwards by taking the total cost and dividing it by the number of FTE to work out what these things are. And interestingly, there is variation between the states. So for New South Wales, if you look at the staffing FTE per state, Queensland stands out as being a bit higher. Now, these numbers are getting quite small because we're talking about 5 to 8 units per group here, and I haven't done any statistical stuff to see if that's just a random variation or whether it's statistically meaningful, but it does sort of support the idea that Queensland's more expensive, partly because they might have a medical staffing model that's higher than other states. And you can see that the dollars per FTE aren't too much more, but you multiply those together and it's a bit more. And South Australia, for some reason, has a much higher cost per FTE, but a same number of doctors maybe. And nursing-wise, again, Queensland and South Australia seem to have a higher staffing ratio per 1,000 patient days, but the salaries are variable with that. So this introduces, if you like, a variation in cost that's got nothing to do with the ICUs themselves. Well, some of it doesn't. The salaries probably have nothing to do with the ICUs, and the staffing may do or it may not do. Now again, this is where it starts to get sort of messy, because the FTE per patient day may have something to do with your occupancy. So the people with a lower occupancy will have a higher staff per patient day ratio. So it all starts, I find, to get a little bit circular as to which one's the chicken and which one's the egg. But either way, there is variation between states that isn't accounted for just by, I think, by randomness. Drugs and consumables. Now, I haven't put this in before, but not surprisingly, the drug costs per patient day go up if you're ventilated, as do the consumable costs. The more you ventilate people, the more drugs you've got to use, the more consumables you've got to use. But when we looked at the average drug price per patient day, Queensland stands out here and it stands out there. Now, I've got no idea what that means. Is it artifactual to do with the way we've done the survey, or are drugs and consumables for some reason a lot more expensive in Queensland than they are in other parts of Australia? It's probably be pretty easy to find out if we did a little survey and rang up 5 directors and asked what the cost of propofol was, but we haven't got around to doing that yet. But it might be interesting to do. But again, go back. These things made up, as I say, only about 10 to 15% of the cost. But again, I don't think that's because Queensland's using twice as much drugs and twice as many consumables as everybody else. So what does this mean, and how do I interpret this? Well, it means I think that there are lots of confounders if I want to compare the cost from one unit to another unit. So if your occupancy is higher, if you have more throughput, then it's likely that your cost per patient day will be lower. If you ventilate more people, your cost per patient day is going to be higher. And depending on which part of Australia you work in, your costs will be different. And most of those things are not necessarily within our control if we're thinking about cost as a quality measure to compare between units. Now, it could be that the staffing model is part of what we control, so that if you have a model with lots of nurses here and less nurses there, that one's more efficient and one's less efficient, and we can do something about that. But we can't do much about the salaries because they're generally all set by state agreements. I did try actually to read through the senior medical staff agreements for various states to work out what the basic salary was. But it gets so mixed up with the hours that you work and the out-of-hours remuneration that goes with it that it was pretty much uninterpretable to an outsider without actually asking somebody. Now, the other thing to say is that the cost per patient day is not the same as the total cost, which is really the cost per patient day multiplied by the length of stay. And as I think both the previous speakers have talked about, the length of stay is determined by a number of things, and it individualises to your hospital. So in my hospital, we have to admit a lot of DKAs just because their pH is less than 7.2, I think, or maybe 7.1. And other hospitals don't. There's a lot of variation in whether elective post-op patients come to your ICU or not, and whether your wards can manage CPAP or not. So getting a patient into ICU makes them expensive, and sometimes you can't get them out just because the wards can't do stuff. They can't manage a lumbar spinal drain on the vascular ward. The only place in our hospital that manages the trachea is the neurosurgical ward, so if you've got a trachea, you're staying in ICU, whether you need to be there for other reasons or not, and that extends your length of stay, and we've heard a bit about exit block. So those things make the total cost of your ICU expensive, but I haven't quite worked out a way that we can compare the total cost of your ICU between hospitals, because that's probably the more valid assessment is the way that we're running our ICU more or less expensive than other places? And the answer is probably in the length of stay stuff, not the cost per patient day, although there is variation between So just some more numbers that came out of this that I wasn't going to talk about, but so $4,200 per day. One ICU bed costs $1 million a year to manage. So if you multiply the number of beds in your unit by that, that's what your unit budget's likely to be. So when you open your next 2 ICU beds, there's $2 million gone. Australia spends about $2,016 million on intensive care, and that makes up 3.4% of your public hospital expenditure. And if you're really obsessive, it's 0.15% of Australia's gross domestic product, which is about a sixth of what the Americans spend. So in summary, staff costs make up the bulk of the costs. There appear to be variations in salaries by state, and there's quite a bit of variation in cost to do with acuity and activity, all of which I think means that you can't use cost to compare units as a marker of quality because there are too many other variations that are nothing to do with the quality of what we provide. So I think we can use cost to estimate how much things cost in total, but I'm not sure we can use it for too much else in comparing units. Thank you. And just for more irony, simply red is also an accounting term for you're in the red because you've just lost $2.16 million. Any questions? I better grab the microphone.
Okay, should be okay.
Yeah, cheers. Can I draw you a bit more on the length of stay stuff? Presumably the cost per day is not the same throughout your length of stay. Presumably the cost on the first day is more than the cost on subsequent days. And could difference in length of stay also account for the differences between the states?
I can't answer the first question because you have to do patient-level studies, but I know from other research that that's the case. The first 2 days are the most expensive and then it sort of plateaus off. All I can say is that if you look at people's average length of stay, there's not much variation in cost between units with a different average length of stay. But I think that's just bad maths. And it is more expensive for the first bit. So if you do have a longer length of stay when you shouldn't have one, if you like, it will get a bit cheaper. Any other questions? Excellent. Thank you.